Hello, I am Heather Lee Smith, a physician assistant and diabetes educator. I work at Wake Medical Center's Maternal Fetal Medicine Department in Raleigh, North Carolina, and I'm going to be talking about pre-gestational diabetes and pregnancy. Our discussion is split into two parts. First, we'll talk about the prevalence and definition of diabetes, the fetal anomalies and risk, and then how we use hemoglobin A1c, our blood sugar goals and monitoring, along with preconception counseling. In the second part, we'll really focus on management both before, during, and after pregnancy. Our entire discussion is focused on basic management. So let's get started. Here is an infant of a diabetic mother, born full term, large for gestational age, weighing in at 5.75 kilograms, born by C-section with a blood sugar of 21. This baby girl is definitely the product of likely uncontrolled diabetes. And the focus of our discussion today is how we try to have our babies born with closer to normal weight, either by optimal glycemic control or by monitoring in the third trimester, so that if they are on this trajectory, we can induce and have the baby delivered a little bit early. So the prevalence of pre-existing diabetes in pregnancy is about 1 to 2% of all pregnancies. The two main types of diabetes are type 1 and type 2. A smaller percentage of pre-existing diabetics are type 1. About 10% of all pre-existing diabetics have type 1 diabetics, which is characterized by complete destruction of the pancreatic beta cells. These patients must take insulin to stay alive. And type 2 diabetes, again, much more common, is characterized by insulin resistance, overall insulin deficiency, and obesity. These patients have a huge genetic component. Often they have parents or siblings that also have type 2 diabetes. When we're talking about our gestational diabetics, over half of those will develop type 2 diabetes later in life. And so it's an important time to really counsel any gestational diabetic about that risk. In pregnancy, though, in addition to having this pre-existing disease process, there's the additional insulin resistance from the placental hormones that make managing blood sugars a lot more difficult. So human placental lactogen, progesterone, prolactin, cortisol, estrogen, and so forth really increase the insulin resistance as pregnancy progresses. Here is our long list of both maternal and neonatal risks, ranging from the baby growing too large and becoming macrosomic, to having neonatal hypoglycemia or jaundice. In the first trimester, we have the risk of congenital malformations and neural tube defects and heart defects. And at delivery, there's a risk of birth trauma and operative delivery. For the mother, there's an increased risk of hypertensive disorders and preeclampsia. If they had pre-existing eye disease or kidney disease, there's a risk that it could worsen as pregnancy progresses. So definitely substantial risk here. What I like to remind my patients is instead of focusing on the risk, focus on what can be done about it, mainly managing the diabetes well. This slide shows the risk of fetal anomalies according to the hemoglobin A1c, and it really shows how managing your diabetes well really makes a difference, where if your A1c is close to goal, the risk of anomalies could be 1 to 29 to 1 in 33, all the way when your A1c is up in the double digits, we see a much more substantial risk of fetal anomalies. Which brings us to the vital importance of preconception counseling, because that hyperglycemia in the first trimester is teratogenic. And so it's really important for them to have effective contraception until their A1C can be optimized because it reduces that risk. In order to treat diabetes well in pregnancy, it's definitely recommended to have a team approach of providers from maternal fetal medicine, OB, endocrinology, diabetes education, and dietitian staff. All of this team put together really gives the patient the best chance of managing their diabetes well. And so when we think about preconception counseling, these are all the things that we try to review at Wake Med. This is our list of things we try to do. We want to really focus in on healthy meal planning and how to monitor and count carbohydrates, especially if they're taking mealtime insulin. We want to make sure they know how to monitor their glucose and on what schedule. If they're on insulin, they need to know how to detect and properly treat hypoglycemia. If we're talking about a type 1 diabetic, we want to review how to use ketone strips given their increased risk of developing diabetic ketoacidosis. We want them exercising. We recommend low impact exercise if they weren't already marathon runners or athletes coming into pregnancy. We optimize their medication regimens. So we want to stop any diabetes medications that aren't approved for pregnancy use as soon as they find out they're pregnant. We want to review all of this risk that we've discussed. We want to review that with the patient and help them understand how important it is for them to be managing any other comorbidities as well as their diabetes. So make sure that their thyroid and their blood pressure is all being managed is really important. And then because of their diabetes, we're going to pay closer attention to the baby. And so we want to review how we're going to do that with ultrasound monitoring and non-stress tests. And we want to review that guideline with the patient so that they understand what's involved in the pregnancy itself. Once we find out our patient is pregnant, then we want to do a baseline evaluation. We want to check their baseline blood count and complete metabolic panel. We want to check their urine protein creatinine ratio. If they've had diabetes for longer than 10 years, we'll want to do an EKG to make sure their heart is healthy. We want to make sure that they're taking their prenatal vitamins and getting their folic acid supplementation. We recommend them taking a baby aspirin for preeclampsia prevention, and so we want to review that recommendation with them. They're type 1 diabetic and don't already have hypothyroidism, we want to make sure that their thyroid levels are normal. And we want to make sure that our pre-existing diabetics have seen their eye doctor just because of that risk of worsening retinopathy in pregnancy. The American Diabetes Association recommends dilated eye exams for pregnant patients, both prenatally, every trimester, and postpartum. And here's our treatment. This treatment is nothing new. The old tried and true how we manage diabetes both before pregnancy and during pregnancy involves this four-fold approach where we want them to eat a healthy, carbohydrate consistent diet. In pregnancy, we recommend about 175 total grams of carbohydrates per day, along with that composed of 40 to 50% of complex high fiber carbs, 15 to 30% protein, and 20 to 35% of unsaturated fats. Again, as I mentioned on the last slide, we recommend exercise, things like yoga, swimming, walking for about 30 minutes, 5 days a week. We want them to monitor their blood sugars, of which we'll talk in more detail about in a minute. And then if they're unable to keep their blood sugars at the normal range, at our goals, then we recommend medication. Of course, our type 1 diabetics would have to be taking insulin in order to do that anyway. So our goals for hemoglobin A1c, these goals are pre-pregnancy or preconception goals, is less than 6. We know that that reduces the risk of fetal anomalies. And it also has the lowest risk of large for gestational age infants as well. If we have a patient that has either hypoglycemia unawareness or they have frequent severe hypoglycemia, that A1C goal can be relaxed to less than 7%. And in some cases, we do have to do that. And these are our blood glucose goals. Often for our most of our diabetics being type 2, we recommend checking fasting and then after meals. If they're checking 1 or 2 hours after meals, it doesn't matter. There's no evidence that one number is better than the other. Checking at one time is better than the other. The goals are just different. So if they're checking at the 1 hour mark, we want their blood sugar 140 or less, and at the 2 hour mark, we want it 120 or less. And then fasting, our goal is 95 or less. We know that postprandial monitoring is associated with better glycemic control and a lower risk of preeclampsia, and that is the reason that we do monitor after meals. Although, if we have a patient that's on prandial insulin, which all of our type 1 diabetics would be, and many of our type 2s as well, then we would want them checking before meals as well. So this is just a repeat of that frequency that we just mentioned. How we use hemoglobin A1c in pregnancy, it's really used as a secondary measure of glycemic control after blood glucose monitoring. That's due to the increased red blood cell turnover in pregnancy. We don't have standard lab values, and we don't use it unless we have a patient that's not monitoring and we don't know anything. Then we'll draw one just to have just an idea of where their blood sugars are. And again, here's that schedule of how frequent we recommend monitoring. So if we think about that, we are really expecting a lot of our diabetics to be checking fasting before meals, after meals, and for our type 1s, we recommend middle of the night checking as well. That is overwhelming and very difficult to keep up with, even for the most motivated patients, which is why continuous glucose monitors have been a real advantage and a revolutionary advancement in the treatment of diabetes. The concern in pregnancy is that we don't have a lot of data out there yet about if they're as good or better as finger stick monitoring. However, we definitely get much more data with continuous glucose monitors than with the patients checking 4 to up to 8 times a day. So we definitely would like our type 1 diabetics, especially if they're on insulin pumps, to be using continuous glucose monitors. That said, we really must have a motivated patient that's willing to understand how to use the device and be willing to wear it under the skin. Also, there's the definite issue of insurance coverage, as many companies require prior authorizations. So here's some trials about the use of CGMs in pregnancy. The concept trial showed a mild improvement in A1C without an increase in hypoglycemia and reductions in LGA births, length of stay, and neonatal hypoglycemia. And then there's another study that found no difference in fetal macrosomia, but did demonstrate lower rates of preeclampsia in women on CGMs. And so the American Diabetes Association's yearly publication, their Standards of Medical Care in Diabetes, says this, that CGM metrics can be used as an adjunct, but should not be used as a substitute for self-monitoring of blood glucose to achieve the optimal pre- and postprandial glycemic targets. So that's for pregnancy. That's what they say, is they should not be used as a substitute. And so at Wake Med, what we do is we explain this to patients, and we tell them that it is recommended by the powers that guide our management to do both. to both check 8 times a day and wear this CGM device. What I'll tell you is that practically our patients aren't going to do that. They will wear the CGM and not check their blood sugar that frequently. What I definitely encourage our patients to do is if they feel differently than their CGM shows, we recommend them check. If they feel hypoglycemic, but their CGM says their blood sugar is 80, go ahead and check. And so at least we can get some more data on it. The international consensus for time in range does have pregnancy targets for type 1s, and those targets are greater than 70%. And so that helps us when we download these continuous glucose monitor reports to know how well they're being controlled and if we're able to meet these targets of greater than 70% of that time in range of 63 to 140 at that 1 hour postprandial mark. At the end of the day, using CGMs can be quite complicated for providers. It definitely involves extra steps to both get it approved and keep it on the patient. That said, their life is much easier, and we do end up with much more data of where their numbers are, which makes sense that we would have more data to make improvements in their glycemic control. So what is a CGM and what are they composed of? It is a device that is monitoring the glucose on frequent set intervals, usually every 5 minutes. And it's composed of a small electrode that's worn under the skin. And that small electrode measures the amount of glucose in the interstitial fluid. And then that number is transmitted by a transmitter to a separate receiver. And that separate receiver is usually a mobile phone app now. In the olden days, or a few years ago, it was a separate device that the patient would have to hold. But most of the time now, that receiver is a mobile phone app. And they can look at their phone to see their blood sugar, or with one of them, you can even have the app on your Apple Watch to see your blood sugar from there. These are the continuous glucose monitors that are on the market this year. Of course, there are definite pros and cons to each device. The two most common ones that we see in our office are definitely the Dexcom G6. The G7 was just approved for use in Europe. And then the Freestyle Libre 2. Those are the most common ones we see. The Medtronic Guardian CGM, while it is a freestanding device, most patients that have it connected to their Medtronic insulin pump. So we do see this as well if we have Medtronic pump patients, because those patients must use their Medtronic Guardian continuous glucose monitor. And then the Eversense CGM is a small implantable sensor, but then the transmitter actually has to stick on top of their skin after they heal from this being implanted under the skin. And so that transmitter still sticks on top of them, but then the receiver is a mobile phone app. And again, they often require prior authorizations. And then for our information that we get, you must have an account with each of these companies so that you can download the data through an ambulatory glucose profile. And then you can make treatment decisions based on the data that you receive, their time in range, their glucose trends, any reported blood glucose values or calibrations that they may have done. Can help you with treatment. So that concludes our first part. We will resume with the second part and really jump into medication management. Thanks for your time.